Thrombosis.TV coverage of the 2015 ISTH conference. Thomas Baldrick along with Dr. Sam Schulman from McMaster University. Thank you, sir, for your time. We appreciate it.
You're welcome.
Let's talk about, you had a presentation this morning. Let's talk about your study and its findings.
We studied how to manage patients who are on a blood thinner called Dabigatran. It's one of the new blood thinners when they have to stop it for surgery because of the risk of bleeding. And there are controversies and uncertainties among the physicians when you should stop it. Should you stop it a couple of days before, a week before? Should you give them another blood thinner called heparin or low molecular weight heparin in the meantime? And when should you restart the thinner again? And we had a specified protocol based on the best knowledge available regarding the pharmacokinetics, the behavior of the drug, how it disappears from the body, how it starts working again, and our knowledge of different types of surgeries and procedures and their risk of bleeding. So by following this protocol at 7 different sites, 541 patients had elective procedures, invasive procedures or surgery, and followed this, and we analyzed how many thrombotic events there were and how many bleeding events. So regarding thrombosis, since these were almost exclusively patients with atrial fibrillation, and the risk there is stroke, and we had 0 strokes. We had 1 TIA, which is a minor event. It's neurological symptoms for a few minutes or an hour and then disappears without residuals, 1 out of 541. So that's a 0.2% risk of arterial embolism. And of the bleeding events, we had 10 major bleeding events, so that's 1.8%, which is low in a historical perspective. And importantly, several of those bleedings were because of a major procedure, very big surgical procedure, or repeat surgery in the same area as before, and some were quite unrelated because they happened about 3 weeks after the surgery, but we follow the patients for 1 month, so we have to include everything that happens within a month. So we were overall very satisfied with the efficacy and safety, and that was without giving heparin, without bridging. We mandated no bridging with heparin, only if the patient was unable to take tablets after surgery. If they had, for instance, bowel surgery and the bowel is not working, you cannot take tablets, then you can give injections for a few days with heparin until the bowel is functioning. And there were a few other vascular surgeries when the vascular surgeon wanted heparin specifically. So less than a dozen cases that received heparin out of the 541. And by doing this, we showed that, and having no stroke, we showed that adding heparin to these patients routinely will not give anything extra in efficacy, because you can't go lower than 0 really, but it could increase the risk of bleeding, which has actually been shown in other studies. And we are trying now to inform physicians in different ways, by the written publication, by lecturing, by trying to get this into guidelines, that this type of protocol should be implemented locally so that physicians manage patients in a uniform and evidence-based way instead of everyone doing what he or she thinks is right.
Why is it important to study dabigatran in the perioperative period?
Because the studies that were performed to get these new anticoagulants approved, they mainly addressed their overall efficacy and their safety, but didn't specifically aim at telling us what to do in case of surgery, in case of bleeding. So we need to do that in additional studies afterwards. And with dabigatran, we chose that drug because that was the first one out for atrial fibrillation. And it was already starting to be used in clinics, and we saw all kinds of aberrations. So we said we have to start now with what is available. So we decided on doing it with the dabigatran.
What are your thoughts on using bridging as a strategy with this?
So as I mentioned, I don't think that bridging will contribute anything extra in efficacy. We should remember that these new anticoagulants, they have similar pharmacokinetics to heparin, to low molecular weight heparin. They have half-lives that are 5 to 10 to 12 hours, very short compared to warfarin with 36 to 48 hours. So it doesn't really make any sense to replace one short-lived drug with another short-lived drug.
Where might you go next in this line of research?
So now we want to expand the study with the other anticoagulants that have been approved and are starting to be used. We see many patients on rivaroxaban and apixaban, and the same questions arise there. How should they be managed? So we are including now, instead of 500, we're going to have 1,000 patients with each drug in the study. We're also simplifying the protocol a little bit more so that it will be very practical for physicians to follow.
Dr. Schulman, congratulations on your findings. We appreciate your time sharing your information.
Thank you.